Up to this point, we've kind of laid out the problem. We've talked about our solution to it, and now it's time to show what the results are. So I'm going to go through just a couple slides about kind of the clinical results and the financial implications after the implementation of Ceribell. So the first is we found that we reduced 100% of unnecessary seizure transfers. So what does that mean? Pre-Ceribell, we were averaging about 2.1 transfers a month from Inspira to Cooper for the need of conventional or continuous EEG. So that was 2.1 transfers per month. After we applied it, those number of transfers dropped down to 0.9 transfers a month. I think that's pretty impressive. I think more than 11 patients a year weren't transferred that would have been transferred. Now, I know it doesn't seem like a lot, but I think it's impactful. And I think not only clinically it matters for some of those intangible reasons Dr. Rincon said, but also financially. So I mentioned earlier the cost of transferring, just the transfer cost alone, is on average $7,500 per patient. This is billed to the sending hospital. That's based on data from Inspira's transport company. Now, what we did in terms of increased revenue is we looked first at the cohort, the historical cohort, and we looked at how much money Inspira collected, not charged, but collected for those patients, right? And on average, the group that was transferred in the historic cohort, they collected about $4,000. Now, of course, whenever you have a patient that's transferred, they split the DRG between the two hospitals based on the amount of time spent at the hospitals. So you can see about $4,000 was still collected for stabilization of those patients. Now, when we looked at the Ceribell cohort, the patients that Ceribell was applied to, so this is all 88 patients, there was on average, they collected a little over about $10,500. And so the average incremental revenue increased per patient was about $6,500, or you can see the combined of maybe $13,000 or so, or $14,000 or so. And we were able to, based on the startup costs and maintenance costs of the technology, calculate how many patients would we have to avoid transfer per year in order to make it financially feasible and break even. And our number for our institution was about 8.5 patients. So if 8.5 patients annually avoided transfer, and this isn't a system that uses Ceribell almost 100 times, I think almost 100 times a year, 8.5 patients avoided transfer, we would break even. I think that's pretty impressive. And just looking at our numbers, we avoided at least 12 or 11 patients. So we were able to demonstrate that not only does it provide better care, significantly better care, but it also is financially viable. And I think this slide, it's probably one of the most important slides. And every time I look at it and I think about it, I present it a little bit different because there's just so much here. The diagnostic confidence, when you have available this technology, is so impactful. Having a patient who's encephalopathic or post-seizure and you're not sure if they're still seizing, and even just giving the medications or proceeding with intubation, and there's still this question, and having the ability to definitively rule out seizure makes things, it's just, as a clinician who's standing at the bedside, significantly easier. And so, there's always a scenario where you see a patient, you're concerned, you give them Keppra, you wait till the next morning, you get the EEG and it says no seizure. And you sit there and you wonder, are they not seizing because they never were and I gave them an unnecessary med? Or are they not seizing because the med I gave them actually did the job? And what do? We discharge them on Keppra. How long do they stay on Keppra? Probably forever. So this ability is incredibly important. And of course, better care always leads to reduced length of stay. And this final point, reduced COVID exposure, now, thankfully, it's less of an issue. But at the time, it takes, I'm not an EEG tech, 15, 20 minutes to properly apply an EEG. The tech generally stands in the room and waits. A lot of these patients had COVID. And by doing Ceribell, quickly applying, standing outside the room, watching the seizure burden from the window really decreased the amount of COVID exposure to the technologist, and also those patients that were transferred decreased COVID exposure the entire transport path. And the last thing I'd say is Dr. Rincon mentioned closer to the family. I was highlighting how Inspira is a community hospital. These are patients who's had the same cardiologist, the same family medicine doc for 20, 30 years. These doctors come to the hospital and see them, and removing them from that hospital and the caregivers or the physicians who know them the best is damaging. And not only that, a lot of our patients' families, they couldn't afford the trip to Cooper. They couldn't go and see their family members. And so keeping them at their home hospital where they could get care from the physicians who knew them with their families around them, it can't be quantified.